I'm Dr. Chen Zhao from University of Pittsburgh. Today, I will talk about HPV-negative cervical cancer and precancerous lesion. Learning objective, epidemiology, and clinical significance. Of course, everything about HPV-negative cancer, histopathological feature, reason why the negative HPV test, clinical implication, limitation of primary HPV testing. Finally, which I will agree with me, PEP HPV co-testing is the best method for cervical cancer screening. Now we talk about adenocarcinoma, endocervical adenocarcinoma. Long time ago, we know the endocervical adenocarcinoma HPV positive and also HPV negative. HPV negative, the endocervical carcinoma, including the most common, the gastric type, and the clear cell carcinoma, endometrial, mesonephric type. Remember, all this, most of this type of the cervical adenocarcinoma, they are HPV negative. I give you an example. This is my case. Patient 50 years old. The peptides, the AGC, we call the AGC, they're HPV negative. Patient has a secretion increase. Then the biopsy. Biopsy clearly demonstrates this is an invasive gastric type endocervical carcinoma. They are not HPV related. So this is another case, patient 57 years, also this co-testing. You know, at McGee, most of the women 30 and above, we have pap smear and HPV co-testing. If the woman younger than 30, we use cytology reflex HPV testing. See, this case, the pap smear, clearly this malignant case is a highly cytological atypia, even though you can see nucleoli, you see the cell like a round cell. This is my case. I did a cell block. You can see the left side cell block. You can see the tumor. Also, you can see clearly the mitosis. Then the right side, as from cell block, I do the HNF1 beta staining, strongly nuclear staining. So this is the pap smear. From the pap smear, even though we know the HPV negative, but from the when I do the cell block, we can make diagnosis this clear cell carcinoma. This is another case. Patient also the co-testing. You can see single cell and cluster of cell clearly the cytological atypia. This is a high zero. Then the HPV testing negative. See, then we still call it high grade. Then the biopsy demonstrates this poorly differentiated squamous cell carcinoma. Right side, the P63 staining confirms this squamous cell carcinoma. Then from the biopsy, I did the P16, left side P16 staining deadly negative. Then right side, we do the high-rate HPV MR in situ analysis. You see, no any stain. This is a truly HPV negative squamous cell carcinoma for this case. This is another case, patient, just a recent case, patient 38 years old and co-testing PEP. You can see clearly also the bloody background. PEP is a high grade at least, but HPV, we use the optimal, but optimal HPV testing is negative, the co-testing PEP like this, HPV negative. Then for this reason, I just wonder why HPV testing result negative. I did a cell block. Cell block right side, you can see clearly, you can see the high-grade squamous cell. Then from the cell block, I did the staining. See Ki67, P16, strongly diffusely positive. Confirm this high-grade at least. Then I did the RA scope-ish. You see, clearly the positive. So we call that at least the high-grade still the HPV-related lesion. The biopsy is invasive squamous cell carcinoma. We did the RA scope-ish. You know, the RA scope-ish include 18 high-risk HPV type. We know that in the United States now the Roche, Optimal, and BD and Clarity, they only detect 14 high-risk HPV type. But the RA scope, they include another 4 HPV type. You can see for this case, clearly we can say this case is HPV 26, 53, 73, or 81. One of these 4 type HPV infection. So even though the optimal test is negative, so HPV testing negative cervical cancer, we know that the true HPV negative case, we saw some case even though the RH 18 times 0 negative. Of course, maybe you do the genome sequencing, maybe some case become positive. Also, we can see false negative HPV testing. There are several reasons: dilation of target HPV DNA fragment, and very low, also undetectable HPV type, or inadequate sampling. All these reasons, even though the case is HPV related, but can have the HPV test negative result. We know the purpose of cervical cancer screening detection, the precancer lesion, for example, SIN3, also early detection of cervical cancer, or we can say detection cervical cancer with early invasion. So now we go back to, okay, how about HPV testing result for SIN2, SIN3, or high zero patient? This study I did many years ago, published 12 years ago. This 2,800 case, you can see the biopsy confirms the high-grade squamous lesion. You see, before the biopsy, 1 to 3 years, 17% case had a negative HPV testing result. This is a recent study that before I mentioned the cervical cancer from 2 large women hospitals in China, Fudan University Women Hospital and Huaxi University Women Hospital. You see, this is their SIN2, SIN3. This large number, 15,000 put together, 15,000. Before the biopsy, the study designed for before the biopsy within 6 months. In fact, most of the case have 1 or 2 months has HPV testing. You can see HPV positive rate only 92%. In other words, this is the SIN2, SIN3 HPV. There 8% HPV negative. If you only use HPV as a primary screening, this 8% of the high-grade squamous lesion will be missed. In 2020 G1 WHO tumor classification, you see, we know the cervical adenocarcinoma, right? We know cervical adenocarcinoma HPV dependent and HPV independent. Even though in WHO book also they clearly mentioned squamous cell carcinoma also the HPV independent. You see, I copied this sentence from this book. 5 to 7% of all cervical squamous cell carcinoma are negative for HPV, even when very sensitive technique for HPV detection are used. Of course, little know about the molecular abnormality, and we know the most if HPV related by HPV pathway. So how about this patient if no HPV related? What's the molecular pathway? Even though the people think about maybe PV3 mutation, some related. Anyway, it's not clear. Little no. In the past few years, several papers report the HPV negative squamous cell carcinoma of cervix, their precursor lesion, we talk about SIN2 or SIN3 are different. The different in the HE staining, morphology different. Also, the molecular pathway, you see here some, the p53 mutation also can occurred. So this is the interest study published in the American Journal of Surgical Pathology. The fact, what is the fact? We say from screening, cervical cancer screening part, HPV testing negative. What percentage? Okay, we can get a conclusion. 10% cervical cancer HPV testing negative, include true negative or false negative. Anyway, the screening test, 10% can be negative. 20 to 40% cervical adenocarcinoma will be negative, especially for the special type, gastric type, clear cell carcinoma, mesonephric type. 5 to 10% SIN2, SIN3 lesion will have a negative HPV testing result. So we see true HPV negative cervical cancer do exist. Also, we know that false HPV negative testing do exist. So this picture give you an impression what is the fact. Now we talk about the guideline. We know there are a lot of guidelines. USPSTF guideline 2018 first time put the HPV test, primary test every 5 years in the guideline. Then the ACOG gynecology group, the same with the guideline, and the CDC also the same guideline. 3 methods, right? Cytology after 30 to 65 years, 3 methods, cytology 3 years, HPV primary 5 years, or co-testing 5 years. Be younger than 21 to 29, this guideline still use cytology, the HPV reflex test. But in the American Cancer Society 2020 guideline, they changed big. They started screening in 25. Also, 3 guidelines, the HPV test only every 5 years prefer this guideline. So now in the United States, debatable is HPV primary screening or co-testing. This is still debatable in the literature, in the meeting. We should, based on the fact, what is the true word, what is the clinical practice. Okay, this slide shows you the 3 large studies. Kaiser study is 623 cervical cancer. Then the Quest study, more than 1,000 cases. UPMC, our data have 129 cases. Cervical cancer, then based on the previous history, the green zone, I want you to pay attention to the green zone. Green zone means HPV negative, PEP positive. PEP, this means at least ASCAS plus. You see, this can see whether the HPV negative case is more or less. From Kaiser study, you see the green zone very narrow, but in the Quest and UPMC studies, the green zone is very wide. This means a lot of cases has PEP positive HPV negative history. So this slide shows you more clear and the Kaiser data. Now we can see the contribution. Relative contribution of cytology over HPV alone. This means co-testing compared with HPV alone. What makes the PEP make the contribution? In Kaiser studies only 7%. This means very few percent of the case. This means PEP positive, HPV negative. But Quest data 21%, UPMC our data 25%. So will depend on the cytology, your technology, cytopathy, how you send out the PEP. See, but the guideline uses data from Kaiser. Why? Because the guideline made by Cancer Society, the Kaiser data NCI supervised involves the study. So this is the, but we think Quest and UPMC data more like reflect current United States practice. This is what we saw. So what is the additional benefit of Pap test compared to HPV testing? See, no person talk about that. You see, this as a pathology, this fungus, this trick, this herpes. You see the Pap smear. Also, you can find this microbiology provide some diagnosis for clinical treatment, right? But HPV not. So another thing, we know the cervical cancer screening. What's the purpose? Purpose for cervical cancer, but not for endometrial carcinoma. But in this study, I think we published 2016, this McGee UPMC data. We checked this more than 400 endometrial carcinoma. I can see 51% within the tissue diagnosis has abnormal Pap. Most of them is AGC related Pap cytology. Even so, from this data, we can see Pap can make some contribution to the diagnosis of endometrial carcinoma. But we know endometrial adenocarcinoma, HPV will be negative. So HPV with no any contribution to endometrial carcinoma diagnosis, we really think the Pap can. So this is the HPV vaccine. We know in the United States, young girl, a boy, maybe now 70% has a HPV vaccine, doesn't 1 dose or 2 dose. Once HPV vaccine get widely used, once HPV vaccine play important role, we will know that ratio of HPV negative cervical cancer will be increased, especially adenocarcinoma. The disadvantage of primary HPV screening, we know that even though entire United States, most of the society approach for HPV primary screening, but their disadvantage, lack of specificity, require integrated infrastructure. Since HPV infection is so common, positive tests may cause undue anxiety. Sensitivity for detection SIN 3+ is better than Pap cytology. Everyone thinking this way, but may lead to overdiagnosis. The last one I show you 2 studies. This study from mainland. This is the largest study and the best study, prospective study. You see the HPV arm and the Pap test arm. The test Pap only, HPV only. Each arm about more than 100,000 women. They follow up a few years. This paper published in 2013. Follow up 3 years, I think, at that time. From this study, they get a conclusion. Commonly believe that routine screening with HPV tests work better than that with Pap testing. Everyone thinking this way. But their randomized study result show sensitivity of HPV testing was similar to that Pap testing, but caused more over diagnosis. You see their conclusion. In this group, they continue the study. You see, the previous paper published in 2013. This paper published in 2024. This means they increase the follow-up time. You see, 236,000 individuals, 25 to 65, in the 2 arm, 1-to-1, the HPV only test or cytology only test. So finally, the conclusion, this follow-up about 15 years in that kind of setting with a low incidence of cervical cancer in their country. They think HPV and cytology screening show similar effectiveness. Similar, only compare HPV and cytology. So in my talk, based on, I really think PAPs in the United States, Pap cytology and HPV co-testing is the best effective approach for cervical cancer screening. In fact, in the United States now, women 30 and above, most of the institutes still use the co-testing. Younger than 30 use cytology. HPV primary screening maybe will be increased, but now I think they are occupy the market maybe 5%, even though the percent may be not accurate. Okay, thank you for listening.